getting to understand who everybody is and, what everyone brings. And, you're not really getting into the work until like the third or fourth meeting. So to have like 5 or 6 months is just really,
Breathtaking.
yeah, yeah. Okay. So I think we have everybody. And just so everyone knows, we have invited two guests today to be with us. And Wendy, I don't want to murder your last name. So if you want to just help me, I'm thinking I'm not even going to try it. So Wendy, can you pronounce it for me?
Yes. Hello, everyone. My name is Wendy Jiang. Thank you so much for having me here. So good to see you all.
Okay, so that was easy. That was that was easy. She is one of our guests today. Wendy has been working on a white paper as part of the Yale Law School, and as we met on the Pediatric Coalition, the Pediatric Palliative Care Coalition group. There's so many groups, I sometimes lose where I'm meeting people at. And we were talking about the work that both groups are doing, and there's so much that we're doing that is separate, but the same thing, that I thought it would be great if Wendy could join us today, and talk a little bit about what her group is doing. And then I also asked Eileen O'Shea to join us today, so that we have brought up doing training or a center of excellence, and how do we help with the staffing crisis that we see sometimes with pediatric hospice nurses and just nursing in general. So I thought that it would be good to hear from her. I also want to bring everybody up to speed before I'll let them say a little bit about what they're working on, especially Wendy. I did hear from Senator Anwar today. Um, Although they understand and appreciate the need for extended time and can give us extended time, they would like some type of language around the framework of what we're doing, so that they can fill in the language into the bill that they have about following, mandating that they follow the recommendations. So we will be at the next meeting with the whole group, to go over what we feel the framework is and the language to put in what we would present to them, and then present that, for the March 1st deadline, but continue to do some work after that to really pull things together. And I feel like I'm talking at everybody, because I was so excited when I had the opportunity to talk to Wendy about what they are doing for their white paper. It's just been amazing. Oh, I see Senator Anwar is on.
I just joined in and I heard my name, so I just appear as soon as you take my name.
That's amazing. We were just
Yes.
talking, Senator. So what we can bring you up to speed on is we have come really far in the amount of time we've had to do this work. And where we're at now is we know where we need to go. A lot of work has been done, and we can give you the framework of what we think needs to be done, but actually building that program will take a little bit longer. However, we have all the framework and can give you the language of what we think needs to happen. And we have the help now from the Yale Law School that is working on a white paper for the same thing. So the collaboration is kind of starting today.
Thank you so much. Thank you for each and every one of you for what you do. Your good work is going to provide comfort to somebody, and then a family. And that's the most important part of it. So I cannot thank you all enough. I was in a public hearing, but I wanted to just come and thank you for the work you do, and any information you can provide us so we can actually start the bill, and then we can probably have a public hearing on the conversation. That would be helpful so that we can pass something this session. And if there's a money that is required, then we can start to do the groundwork. We don't know if we'll get anything. We don't want to kill the bill because of the money. There's other bills that we are looking at for that aspect, but your insight, your vision, and your thoughts are going to be very critical for us. And I can't thank you enough for each and every one for your donation of the most expensive, most important thing, your time and your wisdom. So thank you.
Thank you so much, Senator. And we were saying the next time we meet, it will be the whole group. This is just the subgroup, and then we can present to you what we've been working on to date and what we will be presenting for language in the bill.
Thank you. I'm going to
Okay.
jump back to the public hearing I was listening to.
Absolutely. Thank you.
Bye.
You're muted, Tony Ann.
Yes, Peter?
You are muted.
Okay. Oh, you were saying that thank you. Thank you so much. Kerry, did you want to say anything before we, jump ahead, or are you good with where we're at?
I think I'm good with where we're at. Welcome, Wendy. It's nice to see you. Eileen, always good to see you. I think we're good.
Okay, perfect.
I mean, we have an hour today, right? We're slotted for an hour because the 2-hour meetings are just simply too long.
Oh, yeah, no. We're slotted
hours.
for an hour.
Great.
I'm not sure, Peter, did Kathy send you what Melissa had put together to send out to everyone?
I believe so.
Yes.
Yeah.
Okay, which is the working group to study pediatric palliative care. It's the February 11th that has the date on it, because I know we've had a couple. But she has really put together and summarized what we did at the last meeting, and then what we wanted to look at going forward, which is how things are being done in other states. Actually rebuilding an entire program, which is what we've talked about, and we called it Connecticut Champion Care, I think we were calling it. But I think unless anybody has anything to share right now, I kind of want to give the floor to Wendy and just let her just give us a quick overview. And I'm not even sure, how much you can share of what you're working on, but I think it's just so important because I was blown away when you sent me the bullet points of what you guys are doing.
Well, thank you so much, Tony. And yes, there is, as it just happened to be a lot of overlap, but I think I have a very limited understanding of where your report is at right now and what it's trying to achieve. But I think the whole goal of our white paper is to try to come up with some recommendations that have been proven through research to be effective or good for the pediatric population. And so right now we have like a 20-page white paper that it's very long and it's about to be longer, but we have identified some of the unique challenges that Connecticut faced, including how in depth should I go into this? I can give a kind of like a detailed rundown of what I have, where I can just give kind of like a broader overview of what we're trying to do.
I
What do you think?
it was the bullet points that you had sent me are all the things that we are working on and trying to get the research. The biggest thing for me was where you said that you guys are working on potentially or the idea of rebranding palliative and hospice care for children, which is what we've been working on. And to bring you up to speed too, that's where we kind of have been going. Like, how do we take away the myth of hospice and palliative care? How do we rebrand, using your word, to make it a service that doesn't have certain criteria to it, that doesn't have that hospice, prognosis of 6 months or less. How do we rebuild pediatric palliative and hospice care in the state of Connecticut? How are they doing it in California and Massachusetts and all the things that I was, again, blown away by when you sent me your bullet points? So you can give a general overview if you want, and then if anybody has any questions, maybe we could go from there.
Yeah, that sounds good. Maybe I'll list out the challenges and the solutions that we've identified and we're able to find research backing for. So for some of the challenges, the big one in Connecticut is workforce. We've been able to identify some good stats, although not a lot. And I think that's just one of the big target that we're trying to address this year. And the next thing would be terminology, so confusion with hospice versus palliative, and then looking at some of the consequences of having inconsistent definitions. And the third challenge is stigma. So just like you mentioned, people hear palliative, they think hospice, and when they think hospice, they think that's not something that I want. And then the fourth thing, we have payment. So I remember this was talked about maybe in the last meeting here that once you get on the palliative care reimbursement, some of your existing services might be cut off. And so that's something that we're also looking into, what are other states doing? What are possible solutions? And then next one is regulatory issues, specifically on licensing. So how can we make licensing for pediatric palliative care easier? And if there is a way to do that. And lastly, there are some gaps in services in pediatric palliative care, for example, neonatal gaps and things like that. So here are some of these solutions that we've identified. One thing we're working on is to prioritize these solutions. So I'll just be throwing it all out at you, and I would love to hear, what pops out to you and what seems like a feasible thing to do. And obviously, there's a lot more research that's going into this, as this is incomplete. So to hear just our initial research results. So first and foremost, we discovered that a lot of the research talk about broad goals and broad directions on how we would target resolving these challenges that we've identified. And there are multiple research that suggests that state level intervention can be more effective compared to if you were just to wait for federal action. And so, right off the bat, it's encouraging for us on a state level to be able to have these types of actions. And so looking into how we can have a sustainable workforce, some of the things that we've identified include training pipelines, looking at grant funding opportunities in Connecticut, and then lastly, education. So that could be in schools and hospitals, training the trainer programs, if that's ever of interest to groups in Connecticut. Next up, we have some regulatory adjustment recommendations. First and foremost is definitions. And so, that one of the just fundamental challenges in planning for pediatric palliative care is inconsistent definition of need at the populational level. And so when you have inconsistent definition, you can't have good data because you're collecting data off of things that just aren't the same things. So I think that's just the first step into having a better system. And secondly, I would want to look at the definition for primary versus subspecialty palliative care. I don't know how it is currently implemented in Connecticut, but research kind of suggests that primary palliative care should be, a common, just like something that students would just take as a core, as part of the core curriculum. And then that kind of frees up some of the workforce for that subspecialty palliative care for the most complex cases. And so, one of the good things of this paper coming out of the law school is we have very, very amazing legal people who are looking into how we can change the legal language to be able to sustain this. And so moving on, We also want to look at broadening the referral criteria. One of the issues that we've identified is that children are being referred if they have a complex condition, but many times children can also benefit if they're, acutely ill. And it is not that they're excluded from this referral chain, but rather that it's just not the norm. And research has shown just the incredible benefits that these acutely ill children can have off of pediatric palliative care. And so that is something that we are also looking into, whether it's possible that we broaden this referral criteria. And then the next thing, this one I actually heard from one of the meetings, is requiring hospice and palliative hospitals of a certain size to provide pediatric services. I thought that was just a brilliant idea and something that could be implemented. And so looking at whether other states have done it, and so like what is that threshold that would require this, and what that would look like. So should we require minimum bed requirements for pediatric patients at these hospitals, or should we require funding, reimbursement incentives to support, the infrastructure, or should we, something that like expanded provider training maybe that has to come with this to be able to support this, things like that. And then moving on to the last 2 points, the next one is addressing some of the issues that we have with current practices. So for instance, we can train ICU providers to normalize the pediatric palliative care involvement. There's actually been a lot of research on looking into the benefits of professionals working in the ICU having that knowledge to benefit some of the children that end up in the ICU. And lastly, we're on the rebranding, so integrating a palliative and hospice model. There are multiple researchers that look at kind of the benefits of doing that. And what is really interesting about looking into this is that this is actually quite the opposite with what the adult palliative care field is kind of going for, because I think some of the research done by CAPC recently is really emphasizing the distinction between hospice and palliative care for adult. And it's almost as if they want it to be like two very different things. But whereas if we look at children, the needs of children are different. So it shouldn't just be assumed that, just because you're also people that what works for the adults might work for the pediatric population. So really looking at that distinction between the adults' needs and children's needs, I think is a starting point for us to look at to justify why this rebranding is necessary. And we're currently doing a lot of work in looking at some of the research in this model and what other states are doing about it. And the optimistic thing is that there are research out there supporting kind of this trend. And so we're wanting to use the rest of this week to really look into that. Because this year Connecticut is ranked, I think, number 3 or number 2 out of all the states for palliative care. And so we're definitely up there relatively. And so, if we ended up piloting this like rebranded model, I think that would be a first of its kind to be run in the US. And I think that would just be a great opportunity for Connecticut. And some other solutions that we're looking into is just on data and data collection, and the significance of that is, there lacks a resource platform for families and for providers. And so nobody knows where to find care. And that is because there hasn't just been good data. And so, in an ideal world, we would just say, hey, let's have this platform that streamlines all of these processes and provides information to families and patients, but in reality, those data does not exist. And for the data to be able to exist and be collected, I think that goes back to having a clear definition of what is being collected. And an issue that we see in research and I don't know how that's implemented in reality, is that all we look at is kind of mortality rates, but there is a lot more to just mortality rates in pediatric palliative care. And so really be able to define what data to collect will be the first steps to having data collection and then to having that platform for providers and families. So sorry, I just dumped all of this on you. It's a lot of content that we're trying to cover, and it's going to be a really long paper when we publish, but I would really want to hear your thoughts on if you think I'm missing anything, big red flags, or there's anything that you think I should look into more and prioritize over others, and yeah, love to hear your thoughts.
So
Wendy, this is Melissa. Just a quick question. When do you expect to publish your white paper?
We're hoping to publish this by the end of the month.
Okay. Sorry, Tony Ann.
No. Thank you so much, Wendy. That was a great, overview of what you guys are working on. And I'd be interested, Kerry, in what your thoughts are, because I'm kind of watching your face as she's talking, and I'm wondering what your input might be.
So I think I literally was aside Googling the rankings of states because I'm pleased to hear where I was trying to figure out what that was based upon. Is it access? Do you know what goes into the rankings, and which when you stated you were looking at state rankings, it depends what vehicle you're using, I think, as to where you get those. So was it access based or?
Yeah, so I can send the link. This is the 2024 scorecard by CAPSI. And I have the link, so I'm gonna send it. But I think we're ranked number 2. Let me just send it.
And then I think that one of the things you talked about was like larger hospice being kind of enforced to do pediatrics. And I'm intrigued by that comment because I don't know how that facilitates to providing excellent pediatric palliative care, right? What does that look like? How does that translate to clinical care? If we're saying larger hospices should be doing pediatric hospice, but if they don't have the right infrastructure to do it or the right interest, are you forcing adults to do this care, or what does that look like? So those two things just stuck out a little bit. I think these are large, ambitious topics that will provide a great deal of information. While I want Connecticut to be number 2, I feel like the amount of work I see before us for pediatrics, it's hard to feel that we're number 2. Like, boy, that means the rest of the country's having some issues too. But
So yes, so I will answer both of your questions. So the first one is, so it's not letting me send links. There's no like message.
I can send it because I was on the coalition meeting, so I can send that to Kerry and everybody in the group. I can pull it up and do it.
Okay. Well, great. That'd be amazing. Thank you. So it's the scorecard is by CAPSI and is not on pediatric. So it's the general palliative care, and it is based on multiple factors, not just access. Some of those would include prevalence of hospital palliative care by facility size, by type of community, by location, availability, specialty palliative care workforce, and indicators, like multiple indicators like that. And actually, I mentioned this with the bigger group, but Stacy Sinclair, the executive policy person at CAPSI, she said that if we want, she would be so happy to give us a presentation on our scorecard. So I think, and I think Eugene emailed you this morning about it actually, to continue that conversation if we're interested. But to answer your second question, you mentioned the hospice hospital. So I think I was trying to make a point that for hospice hospitals or palliative hospitals of a certain size, then once you reach a certain size, you should be required to have like a certain amount of beds for the pediatric population. But you know what that size is, whether it be 100 beds or 200 beds or however that criteria is would be determined by you guys are the policymakers of the state. But just the idea that if it's big enough that you should serve the pediatric population, because not all of them do.
Yeah, I think, and that we kind of had thrown that around at the last meeting, saying that it shouldn't just always be based on GIP, right? If you want to do hospice in a hospital for a pediatric patient, it shouldn't just be based on GIP. With Dr. Wolf Gruber had mentioned, because we were talking about, wanting to do hospice in the home, and that's where parents are most comfortable. And she said there are a population, however, that don't feel that comfortable at home and would like to have their child in a hospital setting, but be able to get the benefits of hospice. And as we know, you have to be GIP to do hospice in a hospital. So what would that look like in a new program, so to say, or rebranded program, if we were able to provide hospice in a hospital setting, but they weren't general inpatient level of care?
It's interesting that you mentioned that, because there is a great study that was done recently, and it looked at the availability of hospice and palliative hospitals and people's utilizations of it. And they found that when there was new openings, that people actually used it. When there was a new hospital, a hospice or palliative hospital built, people started using it. So it's like the conclusion was that when it is available, people actually want to be in these hospitals rather than being at home. The issue that, and the reason that a lot of people are left at home or in a non-specialty hospital is just simply that there is not enough of these palliative and hospice hospitals.
So if I can, I know there's people with their hands up. I just want to just the counter argument in pediatrics is siblings and sibling exclusion that often occurs in an inpatient setting. Even when siblings are included to be there, they're playing soccer and doing other things. And if they're at home, if they're at home, there's more. We know that it fosters better sibling grief, and we actually know studies show that better parental grieving is often sought when kids die at home because there's some normalcy, right? I spoke to a mom today that lost a 2-month-old last week, and she just said, you go home and you're back in the same world, and those worlds were separate worlds, and how hard it is to resume your normal life. But it's also just to remind us, one of the biggest limitations to providing hospice care at home currently in the state of Connecticut is the limitation of IV medications and the inability to provide pain management and symptom management other than oral currently for pediatric patients here. That is one of our big limitations. That has to be part of that conversation of where children are opting to die, is that oftentimes kids can't get what they need at home in terms of medications, as we've discussed previously. Just as an aside, but I apologize, Tracy, Eileen, and Karen, who have their hand up, and I jumped in front of you. My mother would be embarrassed. I apologize.
My mother would too, Carrie, but don't worry about it. Thank you. Wendy, I'm Tracy Wodach. I'm the president and CEO of the Connecticut Association for Healthcare at Home. So the hospice providers across Connecticut are members of our association, similar to the Hospital Association and the hospitals being members. So a couple of things that I wanted to ask about the CAPC data and that ranking. I know Carrie thought, "Oh, is that accurate?" Isn't that based on hospital palliative care programs and not any real community palliative care programs? That was my understanding of that data.
I don't know that it is where it isn't, but they have included community palliative, so availability of community palliative care.
Yeah, I guess I'd want to know the name, like who is on the list, because I bet they're mainly hospital based and maybe they have a community palliative program. But I doubt there's too many licensed hospice providers across Connecticut that are part of that community palliative program. There are some that do it, but and then to Carrie's point about the larger programs, I think, were you saying that it was the larger hospital programs that should have a palliative and hospice pediatric program, like a model that might work is to have the larger, I thought you were saying hospital versus the larger hospice programs. Just want to make sure I heard you correctly.
That question's to Wendy, correct?
Yeah, to Wendy.
Wait, I'm so sorry. Could you
So
repeat
yeah,
that?
Carrie had asked about the probability of a large hospice being enforced to have a palliative pediatric and hospice program. And I was thinking what you said in your presentation was a potential solution would be for larger hospital systems, programs to be mandated to have a pediatric hospice and palliative program.
Oh, I actually meant like the hospice hospitals or palliative hospitals.
Oh, okay. So like an inpatient hospice facility.
Yeah.
Okay.
Yeah, like the feasibility of this just general idea is unknown. But I'm, really trying to look at whether there are research supporting this, whether there have been states that have done it, and seeing if we can find something there. But if not, that will not be a prioritized recommendation on this white paper.
So I know we have Eileen and Gail to go. One thing about that is also, I think if you're licensed in the state of Connecticut and you do, hospice, that it should be, you do hospice. We're large enough, you should be doing pediatric. I don't think it should be a kind of thing that we pick and, we cherry pick what we want to do as a large hospice in this, in this state. That we cherry pick who doesn't do charity, who doesn't do pediatrics, who, the nonprofits especially. But that's just, an idea that I had. So that makes sense to me too. But I
You, did you call on me, Tony Ann?
yes, ma'am.
Okay, thank you. Wendy, thank you for all of this work. I do have some questions, and it's to the whole group. When we think about changing the name of pediatric palliative care to branding something other, has there been conversation with clinicians? I can remember years ago being at a national convention for peds palliative care, and this came out as a discussion point about changing the name because no one likes the name hospice. And then we thought, okay, we're going to upstream it and provide an extra layer of support to children with serious illness and their families, and we'll call it palliative care because we can introduce so much more interprofessionals and holistic care. And then when we're really near end of life, then we'll have the hospice experts. And so it took the public and the medical nursing, allied health professionals a long time I still don't think everybody has a good understanding of palliative and hospice. And so to change the name, I would have concern that it's going to take another cultural shift in years for folks to understand, well, with this new name, whatever it is, what does that mean? And is the connotation of palliative and hospice still there? But why don't we just continue to clarify our definitions? I'm concerned that things are going to get muddied and it's going to take more time and maybe some backwards, a backward slide in a little bit, if everybody has a different name state to state, just for consideration. that's one thing I would say. What a clinician saying nationally about rebranding Pete's palliative care. For me, I don't know if it's going to muddy what we're talking about. Is it going to confuse patients and families about the care that we want to administer? And a second point I wanted to raise, what you're promoting, that nurses or healthcare providers should have a basic understanding in their foundational education, that is already underway. So if you look back to a paper, I was a part of it in 2017, we put out a document to support palliative and hospice care in nursing education. So it was a collaboration between HPNA, which is the Hospice and Palliative Nurses Association, along with the American Nurses Association. And we had a call to action saying that all nursing educational programs should be teaching palliative care and care for serious illness across lifespans. So pediatrics, NICU, all the way through geriatrics. And so that call came out in 2017. Also, at that time, nationally, the Hospice and Palliative Care Nurses Association said, we're striving to have a two-tier structure in the US where all, I'm nursing, Wendy. So all nurses coming out of their undergrad program will have foundational education so that they can be palliative care ready upon graduation. That would be the general term. Everyone will be prepared. And then the second tier is those that have expertise. So you're going to call Dr. Moss for pain and symptom management. You're going to call Taryn Hamray for pain management for these kids. That the routine care is not effective. We need help. We're going to call in the experts. And most of the experts have certifications. So that two-tier level is what the US is striving for. And this is going back again, 2017 or possibly earlier. And then just a point of information, in 2021, the accreditors for nursing programs, so the American Colleges of Nursing, they came out with the 2021 Essentials. And this made my day. So it came out in 2021. And it now requires all undergraduate nursing programs that receive accreditation from AACN must address palliative care, hospice care, and supportive care in their curriculum. And we have to demonstrate competencies in this sphere of care. So that will make the workforce as generalists. There's going to be a foundation. And the accreditors will be looking for this in all of the baccalaureate programs that receive AACN accreditation. So just points of information. I'm happy to send you any of the literature I have, so you know that change is coming. It just takes so long. Okay, that's all I have to say. Thank you.
And I would love that, because I wasn't even aware that 2021, that like there has to be a general, background in with the bachelor's that is palliative. And I mean, that's part of really what I think we look at when we say, well, we don't have enough nurses coming out with blah, 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 or experience. Well, they do.
Well, so 2021, it's only 4 years later, and change is slow. Now, Egan, we're all over it at Fairfield, because
Right.
like
Right.
this. But I really applaud nursing education for holding us accountable because for years and years, everyone was saying, oh, it should be in nursing education. It should be. And actually, faculty will say, we can't add any more curriculum. We already have this mandate, and we have to do A, B, and C. And so there's really no space. And if you don't have a faculty champion, it can slide. Just takes time. But
Can
having
you
a
can you
presence-
send that to me, Eileen? Can you send me what you just spoke about?
Sure.
Okay. Thank you so
Eileen,
much.
I actually read your paper, your 2017 paper.
From HIPNA and ANA,
I think it's the one, it was 2017 paper. I just saw it online, so.
call to action.
Yeah.
See, that's so
That's
many years
great.
ago, though.
And, thank you. And Karen, I'm going to get right to you. I promise you're so patient. But just one thing that I want to get back to about the rebranding. And I don't know that we want to like say, okay, we're, tossing it up in the air and going to call it something else. I think the overall program, like Melissa had just thrown something out, like calling it, Connecticut Champion Care. And this is what it entails, but it should be all together. And it should be, people just don't seem to understand concurrent care. And they just don't seem to understand that, and this is not just the community or the population, but in insurances, and we get this with, Husky, obviously Medicaid and, Medicare with concurrent care. Most kids are not going to have a prognosis of 6 months or less, but if they weren't doing any interventions or treatments or anything, they would. So they should still have the option of being on hospice and not per se having a prognosis of 6 months or less. So by rebranding, I think we're just trying to just overarching, calling it something else that could include, when we talk about palliative versus hospice, it's actually levels of care, right? Some kids just need palliative care and they're really not, over into the hospice realm yet. But should we just define it as levels of care, which each level of care would mean more visits, nursing visits or whatever. Payments would increase by your nursing visits, number of nursing visits, but it'll all be under one main umbrella, is basically like the idea of rebranding, a program. So I think that's kind of where we're coming from. And I totally get like getting people to understand. I will admit, I still have a problem with palliative and hospice. I have to go out. I have Jen Denali here in quality in the office next to me. And sometimes I go out and I say, wait a minute, with this in palliative care, what does that mean? I still don't get it myself. So I totally understand those out in the community that just can't get it. So I appreciate your comments. And Karen, go for it.
Thank you. Wendy, great work. I just want to piggyback off a couple things that Tracy and Carrie have mentioned. We have taken care of pediatric patients, and I know and we are a community provider. I'm part of Yale New Haven Health. So, as a community hospice provider, it's been really hard to change the mindset that hospice is a GIP bed in the hospital. That's 1% of all hospice care in the country. It's really rare that a patient will qualify for GIP, as Carrie Ann said. Most of the patients that we have had in the community, the one thing, and Tracy, we had this conversation, Carrie, it was, a little PD patient that the parents just wanted this little baby at home. The most recent one we had was actually out of Yale. And again, when symptoms were starting to, kind of ramp up, the easiest thing for that provider who was not in tune with hospice was send them into the hospital. And, to watch the anguish on the parents' faces was, no, we want to keep them home. We want to keep this little individual home. and, you know, there was another sibling there. It was a beautiful death. If there, you know, there is such a thing, there definitely is. They made memories with this little child. Her sister made memories. It was just incredible. So I agree, we do need, for those who want to be in a facility, to be in a facility, but I would say probably more often than not, it really is going to be that these families want to be home where it's normal. And Carrie, just to your point about some of the prohibiting things that will prevent children from going home, one being IV access. We are this close to working with Yale Infusion, and we're going to be able to offer PCA pumps in the home. So we will get with our experts in peds too. So we're so excited about that. And that's it.
Yeah, no, well, thank you, Karen. And that would be, I mean, that's amazing. I will tell you that we, right now, regional, we work with Avantum and Partners. Well, Avantum is now Partners.
I was going to say they're this one and the same now.
Yeah, absolutely. We have very little problem with getting pumps in the home. So I know we have with other pharmacies. So it, you know, I don't know if it's just certain hospices maybe that are dealing with certain pharmacies, but Partners, you can get a pump in the home, and Yale doing that now. I mean, I think that is just amazing. And I would totally applaud if Yale opened up and would give their pumps to like just do a general that other hospices could probably, you know, be able to use a pharmacy like that through you. I mean, that would be.
Yeah, I think, you know, nothing is all set, but you know, we're starting slow, and you know,
Yeah.
who knows what the future will bring.
Yeah, no, that would be amazing.
You were muted again.
Oh, okay. So nobody else had their hands up for Melissa.
Sorry. To your point, I think it was Eileen, you talked about the branding. Like Tony Ann said, I don't think there's a conclusion on what's being said. I think, though, you have two different audiences. You have the families and you have the medical practitioners, your experts. And the medical experts, it will take some time to onboard them, but there's not a lack of understanding. I think one of the reasons we were thinking about a different type of messaging was for the families who may be avoiding inclusion of hospice early in the process, so that by the time point where the patient is at end of life, hospice has been there all along. So it's sort of like you don't want to leave hospice out of the communication or the conversation. But if you say hospice up front, or even palliative care up front, families get scared and they may avoid inclusion. And I know, having done this in my work life, developing and branding and delivering programs, it's a huge communication challenge, like no question about it. So it is a kind of a multi-layer and multi-time frame to get people on board with something brand new, regardless of whether it's branded palliative and hospice care or it's something else. So.
Yeah, thank you for that, Melissa. I know I saw Barb here somewhere. There she is. Barb, are we any more responses to the survey?
So I started making calls yesterday. So now that I'm making calls, I am starting to see responses. I can share the preliminary very quickly with what I have. Can you see my screen? So I have 14 responses. We have 88 licensed home care agencies, but I'm going to persevere here. And in some of my conversations, one of the things that we didn't contemplate when we asked what the barriers were regarding challenges with accepting pediatric hospice, there were a few agencies that we just started to have conversations, and their bylaws prohibit them from accepting or caring for any individual who's under 18 or 21. So that's a barrier that we didn't contemplate. But once I have, this is the beauty of Office suite of tools, it does give you charts and graphs as to responses. So once I have a more robust response, I will certainly share it with the group. And then the other thing I wanted to share was our map. And can everyone see the map? Yes, this I'm very excited about. So this is a map that just demonstrates the geographical locations of our licensed home care agencies. So if we hover around the dot, and they're all one color right now, but my hope is to color code, have a legend that demonstrates the geographical location of hospice providers, and then based on the survey results, the hospice providers that provide pediatric hospice services will be their own color. And then if you hover over the dot, it does tell you the home care agency. So this is, our data scientists did this for us. So grateful to them, and they're brilliant. But this is exciting for me to have this, at least a tangible tool where we can see what it looks like. I'll
Absolutely.
stop there and I'll stop sharing.
Thank you so much.
Thank you.
Oh God, this question went right out of my head. Oh, I know what it was going to be. So, needless to say, our next meeting is going to be pretty much what we're going to tell the larger group what we've been working on, what our thoughts on. Of course, I'm going to send that pretty much out to everybody, and we're just going to need everyone's input. And if we're in agreement on what we're saying. But I had one other question for Wendy, because a lot of what we have been doing here and the expertise and experience around this table is all through experience, right? But when you talk about something, and in your white paper, you talk a lot about the research shows, or we've been able to find, or, you have data showing certain things. If I could maybe just send you an email, and you could help me understand where to look or how you found certain things, like that might be really beneficial, because we are going to need to include data in our report. And I think, other than, what Barb is doing, it was one thing that you said to me on the call the other day. What was it? Like, you have the demographics of, or who is using, certain services for pediatrics. If I could, pick your brain on that a little bit, that would be really helpful if possible.
Of course, if you send me a list of things that you would want some support on, please feel free to do that. You can make the list as exhaustive as you would like, and we want to be useful and helpful. And like you said, like the white paper and the format is just that it's literally just compiling research that already exists to help policymakers like you adapt to your circumstances. And it is exactly the expertise and the experience that is lacking. And so I'm so grateful to be here and hear all of your experiences and expertise in it. And there is a lot of interesting stats out there. And for instance, with this whole rebranding thing and, people not being able to get on board with hospice or whatnot, there was a study that actually looked at like the receptivity to pediatric palliative care. And like there's a study that was done very recent, I think last year. And it found that none of the parents who didn't receive pediatric palliative care said that they were not interested. Like that was not the reason that they didn't receive palliative care. And over half of that sample stated that they would have wanted pediatric palliative care to be involved. And so interesting things like that makes you really think like, so what's really going to make the rebranding difficult is going to be the change in payment mechanism when you combine these two. So like, how would you reimburse this big chunk of, services offered? And yeah, so I would be happy to share my draft towards the end of the week with everybody here. I have no problem doing that, as long as it maintains just between us. And if it can be any help to your report, because all it does is just the research, and it's, what is lacking is that key expertise and like relevance within our situations. Yeah, so please feel free to reach out and let me know if I can be of help. And I think maybe after I send out the draft to everybody, you can let me know if you can literally just take information out of this white paper. I don't mind if you just reference it in that way. Whatever it is to help, because I know you guys also have a tight deadline for this. And the hopes on our end is that after we publish this white paper, that the team would write an op-ed on this to really force multiply the efforts that the Yale School has initiated, and bouncing off of everybody here and also the state legislators' efforts.
Absolutely. I welcome seeing the paper. I mean, that would be just amazing. And then also just emailing you some things that I think would be helpful for us to have the research on, because it's always good not to just go with like anecdotally, we think it's this because of our experience. We need to show that, what we're saying is valid. So that would be great. And I so appreciate you being here today, and Eileen. But Tracy, is that a new hand? Okay.
Yes, it is. Sorry. Just a couple of quick things. Barbara, on the survey that you're trying to get answers to, I'd appreciate knowing the 14 responses, how many of them are actually hospice providers versus general home health without a hospice license. I think it's important to report that way. And then the other comment, I can't remember what it was because I know we're at the top of the hour. Oh, Eileen's thoughts. I really am not fond of rebranding any names. I think we really need to try to figure out how to fit in. It's the same thing with home health and home care. There's confusion everywhere about what goes on. We need to just promote and continue to educate. I don't know how else to offer that up, but I know there's fear around death, and that's ultimately the reason for it. So whatever we call it is still going to be fear around death.
Yeah, totally. I totally agree. And I don't think it's like I was saying, it's not, it's for the payments and things and levels of care that I think if we were to put it under one umbrella kind of thing, but I totally hear what everyone's saying. Okay, anybody else have hands up or? Okay, Kerry, anything?
No, I think that I just continue to be so inspired by the thought process. It just feels limitless, the opportunities, but yeah, I think there's some great opportunities, and the concept of access to medications is like blowing my mind a little bit. I know Karen seems like she's dropped off, but access to meds in the home is like a whole different joy factor. So love that things are moving. I just don't see the timeline is just so short when you think about everything we're trying to do. But
I can add just quickly that Connecticut Hospice has gotten a grant to expand their pharmacy for home infusion, but they're not at all interested in doing pediatrics at this point.
Right. Yeah. And we're also have been talking to One Point, but we haven't gotten a clear, green light with PCA pumps in the home. But Partners does, we put them in the home. So they have been very supportive and have been able to help us do that. So we'll just keep plugging along. But Thank you, everybody. I will send out some emails about what we're looking at putting together and then talking about next time we meet, but we will have the larger group next time and we'll go from there. So thank you all very much.
When's the next meeting, Tony Ann?
Peter, help me.
I believe it's the 25th at 2, February 25th
Yes,
at 2
perfect.
p.m.
Yes, and just, for Peter, my buddy here, do we get a motion to adjourn?
So moved.
Okay.